Accurate measurement of the blood volume has challenged physicians for nearly half a century. Until quite recently, the methods for measuring the blood volume were slow, cumbersome, and in serial determinations, increasingly inaccurate with each successive determination. Techniques been so improved and simplified that rapid, accurate blood volume determinations can be made routinely. Today, it is a patient's bulimic state in less than 20 minutes, and to make accurate serial determinations as often as every half hour if necessary. Because of this new ease with which blood volume can be measured, it is worthwhile to examine more closely the indications for such measurements and the value derived from them. That is the purpose of this film. First, a few figures. Just what is a normal blood volume? In the average healthy adult male, the blood volume in milliliters equals 7% of the body's weight in grams. In the obese male, the percentage drops to 6.5. In a muscular athlete, it rises to 7.5. The corresponding figures for the female are 0.5% less. 6.5, 6, 7. In young children of either sex, the accepted figure is 9%. From infancy to puberty, the amount of blood relative to body weight decreases about equally in boys and girls. After puberty, it decreases more rapidly in the female. Once the adult blood level has been established, however, it remains remarkably stable throughout life, except during pregnancy, when it may increase up to 50% above normal. Postpartum, normal bulimia is usually restored within 24 hours. Most people, healthy or ill, are normal bulimic. The cell-to-plasma ratio is normal. Even those who suffer from anemia usually have a normal blood volume because their chronic red cell deficit is made good by an excess of plasma. Hypovolemia occurs when whole blood has been lost by hemorrhage or when plasma has been lost, either by massive extravasation into traumatized tissues or through severe dehydration. A mild fall in blood volume is usually quickly reversed by mobilization of tissue fluids. But when the loss is severe and rapid, so that fluid reserves cannot restore the normal volume, the deficit should be made good by giving that component of the blood which has been most depleted. Whole blood after hemorrhage, packed cells in anemia, or plasma and other fluids after extravasation or dehydration. Hypervolemia occurs in polycythemia vera. In this disorder, the cell-to-plasma ratio is elevated. Hypervolemia also occurs in congestive heart failure, in some forms of acute renal failure, and in eclampsia. In these disorders, the cell-to-plasma ratio is usually normal. Hypervolemia may also be caused by injudicious overtransfusion or by excessive absorption of fluids during artificial dialysis for renal failure or drug poisoning. Both hypovolemia and hypervolemia are harmful to the patient. Severe hypovolemia means reduced cardiac output and therefore insufficient flow of blood to the tissues. The resulting generalized vasoconstriction is harmful. Urinary output is reduced. Retention of acid metabolites and tissue anoxia produce a mounting acidosis that leads to respiratory overload. Poor flow through the intestines reduces the absorption of water, glucose, and other substances. Poor flow through the liver and spleen causes progressive decline in the antibacterial defense potential. Efficient flow through the coronary vessels impairs myocardial contractility. It is obvious that in such circumstances it will not be more than a few hours before some vital function begins to fail. In hypervolemia, increased cardiac filling may overwork the heart, causing pulmonary engorgement, respiratory distress, and other effects of congestive heart failure. This hazard is particularly dangerous for patients who already have a cardiac disability. Now, let us consider some clinical examples in which attention to the blood volume is of major importance. This is the victim of an automobile accident. He is in shock, and so has lost at least 1/3 of his blood volume, or about 1,500 milliliters. This amount will be the minimum replacement required. However, even if this much is transfused and the signs of shock disappear, the patient may still have a deficit, either because the original loss was greater than 1,500 milliliters, or because he is continuing to bleed considerably. As this deficit is a burden that the patient should be spared, it is important to know exactly what the blood volume is, so that the loss can be replaced fully and as soon as possible. To assess the full deficit, the blood volume is now measured. This is how it is done by a dilution method which uses RISA, R-I-H-S-A, a radioiodine-labeled human serum albumin preparation. First, the syringe pre-packed with the RISA is inserted into a specially designed blood volume measuring instrument, which now determines and remembers for later the exact amount of RISA in the syringe. Now the physician or a technologist collects a sample of the patient's blood and fills a special heparinized pre-mixed tube. A fraction of this sample is taken for a 2-minute hematocrit. The RISA is injected into the patient's vein. Here, care must be taken, as the smallest fraction lost into the tissues will give a falsely high value for the blood volume. If such a leak should occur, the entire procedure must be repeated from the beginning. The syringe is returned to the instrument, which automatically subtracts the amount of radioactive material left in the syringe from the previously measured total. The instrument now remembers the actual amount of RISA injected into the patient. 10 minutes later, when the RISA has completely mixed with the patient's blood, a post-mix sample is collected. And the post-mix tube is filled to above the mark. Both tubes are inserted into the counter, which now measures the difference in radioactivity of the two samples and calculates the dilution of the injected RISA. The patient's total blood volume in milliliters is read directly from the dial. Multiplying the total blood volume by the hematocrit gives the red cell mass. This, subtracted from the total blood volume, gives the plasma volume. The value of the total blood volume prior to the injury, that is the normal value, is obtained from the body weight blood volume formula. With these figures, the physician now prescribes the correct transfusion therapy. Sometime later, a second determination shows that further losses have occurred since the transfusion. Additional therapy is required, and the blood volume is again measured. This monitoring of the blood volume is continued until it is clear that the normal value has been reached and remains so. This type of blood volume determination is accurate and a far more reliable guide to therapy than estimates by less direct methods or based on clinical judgment. The 10-minute mixing time for the RISA has been proven sufficient even in very sick patients or terminal patients with failing circulation. The total radioactivity of one dose is less than 5 microcuries, or about 1/20th the amount of radiation the patient would absorb during a conventional chest X-ray. Blood volume determinations are desirable prior to, during, and after elective surgery in which large losses of blood or plasma may be expected, as in radical mastectomy, neurosurgery, gastrectomy, or abdominoperineal resection. The initial preoperative determination gives a more accurate baseline for subsequent therapy than the value obtained from the body weight formula. The measurement also serves to reveal any red cell deficit, a common occurrence in the chronically ill or depleted patient. If such a deficit is found, it is corrected by the administration of packed cells. During major operations, blood volume determinations are of significant value. Estimating blood loss during the operation by conventional methods is highly approximate because whole blood and plasma leak into the traumatized tissues where they cannot be reached for direct measurement. During major surgery, even experienced surgeons can err by 1,000 or 2,000 milliliters in assessing the total loss. The undertreatment resulting from such errors is here avoided because losses are monitored throughout the operation. Volume deficits are replaced nearly as fast as they occur. Furthermore, with accurate blood volume information at hand, there is no danger of adding a dangerous hypervolemia to the patient's burden. After the operation, untoward signs suggesting hidden losses are obvious indications for monitoring the blood volume. Hidden losses may be caused by bleeders. More often, they are due to a large loss of plasma into the area of surgical trauma. Such losses may be so extensive as to threaten or cause vascular collapse. In the absence of correct blood volume data, such developments are often mistakenly ascribed to surgical trauma or to myocardial infarction. In fact, a myocardial infarction frequently occurs after operation, either spontaneously or because of a failure to relieve a dangerous hypovolemia. Here, the heart condition developed spontaneously. 3 days after the operation, our patient went into sudden vascular collapse. A myocardial infarct is suspected. The blood volume determination quickly rules out postoperative hypovolemia as a possible alternate explanation for the collapse and forestalls the administration of blood or plasma, which could produce a dangerous hypervolemia. In patients with severe uncontrolled infections, especially those which are caused by gram-negative bacteria, shock is a common complication. The blood volume may be either normal or low, and if it is low, blood or plasma can be of benefit. But if the patient is normal bulimic, transfusion is not only unnecessary, but potentially dangerous. Here is a different situation. This patient suffers from obstruction of the small intestine. He has generalized vasoconstriction, a blood pressure of 80/60, a rapid weak pulse, and a sweaty skin. Hypovolemia is severe because he has lost into his intestine large amounts of water, some of which he vomited. In addition, he has lost considerable amounts of plasma into the peritoneal cavity as well as into the intestine. In a severe case such as this, water, dextrose, sodium, and potassium will restore only part of the deficit, and sustained restoration of normal hemodynamics requires plasma or plasma expanders. The actual amount required is determined by repeated blood volume determinations. This patient has a long history of duodenal ulcer and has just been admitted following several days of increasing pallor, weakness, black stools, and finally, a severe hematemesis. He is pale, has tachycardia, and a blood pressure of 94/50. A blood volume determination is requested. The volume is 4,000 milliliters, and the hematocrit 23. Since he weighs 70 kilograms, his normal volume is about 5,000 milliliters, and he therefore has a deficit of 1 liter. His red cell mass, which should be about 2,000 milliliters, measures only 920. The low hematocrit signifies previous bleeding and dilution of the red cell mass with mobilized extravascular fluid. He therefore receives 1,000 milliliters of packed cells. Now the blood volume is 4,850 milliliters and the hematocrit 40. But by noon the next day, he is still pale and the tachycardia persists, suggesting continued bleeding. His blood volume has decreased to 4,100 milliliters and the hematocrit to 37. Accordingly, he now receives a liter of whole blood. By the evening of the same day, the patient's blood volume is 5,100 milliliters and the hematocrit is 40. He is pink, warm, dry, and comfortable. Next morning, the blood volume has decreased slightly to 4,800 milliliters, but the hematocrit has risen to 42, indicating that bleeding has stopped and that excess fluid is being removed from the blood physiologically. Here is a patient with polycythemia vera. Periodic blood volume determinations have shown that his blood volume has been steadily increasing. Venesection is required, and volumetric determination shows exactly how much blood should be removed. In such a case, the blood volume determination takes all the guesswork out of the treatment. You have now seen some of the conditions and situations in which blood volume determinations can be of significant value. Let us summarize. Blood volume determinations are useful for assessing the need for transfusion, the type of transfusion, and the exact amount to transfuse. The measurements are also valuable in preventing excessive transfusion, which can be harmful. Blood volume measurements help the surgeon during surgery by accurately determining how much blood has been lost, and after surgery by detecting concealed bleeding or excessive extravasation of plasma. In the presence of grave hemodynamic imbalance, blood volume measurements allow one to incriminate or exclude volume loss as a cause. The physician can use blood volume measurements to follow progress in certain forms of therapy. For example, if a patient with congestive heart failure has a hypervolemia, the effect of diuretics and of other drugs that reduce congestion can be measured directly. When there is a sharp drop in blood pressure, blood volume measurements allow one readily to distinguish shock caused by hypovolemia from normal volemic shock caused by sepsis or myocardial infarction. These are some of the major surgical and medical applications of blood volume measurements. Other indications are found in gynecology and obstetrics and in endocrine disorders. In fact, as experience with this new diagnostic tool grows, new indications for its use are constantly appearing.